Hi guys, welcome to my blood gas mini series as I promised. I have broken down blood gas into bite-sized chunks, and I think I've made quite a difficult subject pretty easy. And hopefully you'll agree. We're just going to do part one, which is pretty much just the pH part of the blood gas, and rather than dealing with the gases themselves, the oxygen and things, than the arterial part of the sample to see how well the patient is ventilating. And we're actually just going to concentrate on this video in the pH part and get our heads around that, and then you guys can then start trying to interpret your blood gas at work with these handy little tips I'm going to give you. Hopefully you find it interesting. I've quite enjoyed putting this together. Nice, simple, quite quick video. So yeah, let me know what you guys think. We're going to dive straight in first of all. When we measure the pH of our sample, we're essentially measuring the amount of hydrogen ions within that sample. The more acidic our pH is, so the further down the scale it is, the more hydrogen ions we have. The more base our sample is, or the higher up on the pH scale it is, this scale I'm referring to here, so we get into the blue section, the less hydrogen ions we have. So it's a little bit of an inverse relationship. So just remember, when the pH is low, we've got more hydrogen ions. And when the pH is up, we have less hydrogen ions. So it's the opposite, essentially. And the normal range for our patient's pH is around the 7.35 to 7.45 mark. And the body does try and maintain the pH within that range. It can get a little bit out of whack if it does go either too low or too high, particularly in acidosis. If there are too many acids, the body's enzymes don't work and systems start to fail. So it really does try to maintain the pH within that nice balance and that nice reference range. And the next big player that we need to look at is bicarbonate. Now, bicarbonate is the main buffer of extracellular fluid. And he's really important. His job is to pretty much mop up hydrogen ions and mop up acids. And generally speaking, when we have acidic blood, we have low amounts of bicarb. When we have more alkaline blood, we have higher amounts of bicarb. So also quite a good one to try remember, so you can place bicarb. Normal reference ranges for him, they do vary in different texts, but sort of 20 to 24 is generally accepted as normal. So once we know the pH of our sample, we need to determine what the primary problem is and what our compensatory changes are. Now, the primary problems that we're going to look at today are going to be two things. We're going to be looking at metabolic disturbances and respiratory disturbances as our primary problems. And then because they're an issue, the body then tries to compensate, and we get these compensatory responses. And that's what can make blood gas interpretation a little bit difficult, because the body doesn't make it so simple as to, this is the problem, here we are. It's, okay, this is our numbers, the body's trying to compensate, and that can make it tricky and difficult to interpret because the body's kind of masking what might be going on. I will say at this point as well, you can get mixed disorders, but we're not going to talk about those within this video. We're literally talking about just metabolic or just respiratory. They're the most common. You don't tend to see mixed very often, but I'll cover it in another video if people want me to. So let's look at my metabolic first. Our biggest indicator that we have a metabolic process going on is that we look at the pH and we look at the bicarb, and both will be trending together. And what I mean by that here, you can see with a metabolic acidosis, we'll have a low pH, going down into that low range of our pH table, and our bicarb will follow it. Okay? The opposite with metabolic alkalosis, where our pH is higher and outside of our normal reference range, and our bicarb will also be higher. They trend together. So if you can try and remember that, it's really good. I think it's a really good little gem, really good little trick, that in a metabolic process, we look at the pH and the bicarb, and both will be trending together. When we get a respiratory problem as our primary problem, so there's a problem with the lungs or a respiratory system, it's a little bit the opposite. And we don't look at bicarb, we look at CO2, carbon dioxide, because we're dealing with the lungs. So when I say the opposite, it'll be the CO2 will be opposite to our pH. So again, we've got a respiratory acidosis. So our pH is low, it's of the lower end of the scale. And when we look at our CO2, it'll actually be high. And so the opposite, as opposed to the metabolic indicator, where both are trending the same. With the respiratory indicator, they trend opposite to each other. So when we have a respiratory alkalosis, our pH is going to be high and our CO2 is going to be low. Okay, so that's again the next gem or the next tip to try remember to be able to determine respiratory from metabolic and what the primary problem is. So just to recap, step one. Step one is simply taking our blood. Step two, we run our blood and we find out what our patient's serum pH is. Then we have to determine what the primary problem is, because it may not be obvious at first when you get all those numbers. So we look at the bicarb and we look at the CO2 and we determine which is trending with the pH to try and figure out, are we dealing with a metabolic problem or are we dealing with a respiratory problem? Step two, once we've tried to confirm the primary problem, we then determine what our compensatory changes are. And there are two compensatory response systems in the body. We've got a slow response system and we've got a fast response system. So we're going to go and look into those. So our kidneys are the slow response system. Our kidneys try to regulate pH by excreting hydrogen ions and reabsorbing bicarb. And it does that to try and balance the pH. Now, it's a slow response system because it can take hours to days. If we get a patient that presents quick enough, we might not see that this patient's had time to compensate using the kidneys. However, the opposite, if a patient has been left at home and should have been seen sooner, we might find that their compensatory phase is set in, and we'll see that on blood gas, or we may see that. The fast responding system happens almost immediately, and it's the lungs. They're the ones responsible for it. And they can pretty much try and regulate pH by simply increasing or decreasing the respiratory rate, okay, or respiration. Like I said, it has immediate effect. We've got to remember that CO2 is an acid, okay? So if the body has too much acid, if we're dealing with an acidotic process, the patient may start to pant or hyperventilate to blow off some of those acids. At the same time, if the patient is too base or too alkaline, they might try to hold on to some CO2, some acid, by reducing respiration. It can only do that so much, as the patient still needs to oxygenate, but it is the compensatory mechanism that can happen. Pretty interesting. So let's try and put what we've just learned all together, okay? Metabolic acidosis. Our pH is low because it's acidosis. We see that it's metabolic because we look at our bicarb and it is also low. They're trending together. They're both low. And our compensatory response to that our patient may do is they will try to reduce the amount of CO2 in their body by increasing their respiration. That is seen quite often, that one, a metabolic acidosis. And a lot of bad disease processes, we get a metabolic acidosis. Metabolic alkalosis. Our pH is too high. It's higher than what it should be. And we know it's metabolic because our base will also be high. It'll be trending upwards with the pH. And the compensatory response we may see from our patients is an increase in CO2, an increase in acids, as they try to hold on to some acid, because their problem is they're too alkaline, they're too base. So they want to try and hold on to some acid to bring their pH back down, that nice green zone that we want it in. And it'll do this by decreasing that respiration. Respiratory acidosis. So our pH is too low, it's lower than normal range. We then look at the CO2, and that is higher because it's respiration, it's opposite. pH is down, CO2 is up. Okay? And the compensatory mechanism we may see from this is an increase in bicarb. So the kidneys they will excrete the hydrogen ions and they will reabsorb the bicarb in the kidneys to try to pull back so they can try and tackle some of that acidosis with some bicarb, get that bicarb back into the body and mopping up those acids. And respiratory alkalosis. So our primary problem is that our pH is high or it's too base. So we look at our CO2. Our CO2 will be low. That's what tells us it's respiratory. And the compensatory mechanism for this will be excretion of base. We don't need any more base. Excretion of bicarb. We don't need any more bicarb. Our pH is too base. So we don't need any more. Get rid of it. Okay? Get rid of it in the urine. And they're the kind of things we do see. And if you can try and just commit those things to memory, remember that pH, the more hydrogen ions we have, the lower the pH. Remember that inverse relationship? The higher our pH is, the less hydrogen ions we have. That's the first thing to remember. And the second thing to remember is that with a metabolic process, both our pH and our bicarb will go together. They'll trend up or down. And with a respiratory process, we look at the CO2 and they will trend opposite to that will trend opposite to the pH. So when the pH is up, the CO2 will be down. And that's what tells us it's a respiratory process. Okay, I really hope that makes sense because I feel that's a really good way of remembering that this is not an easy subject by any stretch. And I think it's a good way of remembering it. So if you do want any more clarification, please get in touch. Social media, just message me. It's fine. So let's look at some of our common reasons why we get these processes. So metabolic acidosis we see very commonly. We can get that through bicarb loss, simply through diarrhea, dilution. We can get it through acid gains. And we can get those from, this is where we have the acronym DUAL, really good acronym. These are the reasons for producing acids, for the body producing acids. We've got diabetes, we've got uremia, so our renal patients, ethylene glycol toxicity, lactate, so that's all our shocks in there, that hypoperfusion that produces lactate. We've got impaired hydrogen excretion, so all our kidney patients where their kidneys don't work properly and they can't excrete the hydrogen, that will result in the retention of hydrogen and acids. Metabolic alkalosis we see commonly in our foreign bodies. Upper GI foreign bodies, they vomit up a lot of acids, they become alkalotic. If next time you get a foreign body patient in and you take a blood gas, they're generally pretty typical on blood work. Diuretics can also cause it. Respiratory acidosis. This is anything really that causes a reduction in either respiratory rate or depth. So toxins, cervical nerve injury. If we lose the nerve function from our cervical, from an injury around the neck, then we may lose the respiratory drive to be able to get the depth that we need, resulting in buildup of CO2. Our drugs, think our opioids, they can cause our patients to hyperventilate, as well as our anesthesia. That can, again, the less we breathe, the more CO2 we get. CO2 is an acid. Pleural space disease, any kind of obstruction will build up CO2. Think of asthma, BOAS, foreign bodies, like pharyngeal foreign bodies. And respiratory alkalosis, so things like hyperventilation, so the opposite, and that can come through pain, stress, anxiety, fever, pregnancy, high altitude. There are a number of reasons why we can get these different diseases. So when you do interpret your blood gas, go back to your patient, look at what's going on, talk to your vet, and see if you can try and put the pieces of the puzzle together, because that's what this is really, and it's pretty interesting. I hope you found that really helpful. That is all that we're doing today. Next, soon in my next video, part 2, we'll cover base excess and the anion gas. And then eventually we'll get through to our gases and arterial, looking at oxygenation. Okay, so let me know how this went. Let me know if that makes sense. Let me know if you give it a go at work. I'll post soon some case studies of some actual blood gas results, and we'll go through those. I'll do them in a post. So yeah, look out for that. And look, guys, have a great day, and see you later. Bye.